A healthy metabolic state involves a complex interplay of signaling between the brain and various key organs involved in metabolism, including adipose tissue or fat, signals from the stomach and the gut, insulin from the pancreas, vagal nerve tone, and multiple hormonal signals like GLP-1 and leptin. High insulin levels, seen in states of insulin resistance, predispose the body to store additional fat and contribute to increased obesity. When normal fat stores under the skin fill up and get overloaded, they become inflamed, and the fat spills over into other organs like the muscle and the liver. The fatty liver becomes inflamed and can become fibrotic. It also loses its ability to manage cholesterol derivatives, leading to hyperlipidemia and to increased cardiovascular risk. This state of hyperinsulinemia, inflammation, and hyperlipidemia, along with dysregulated signals from leptin, GLP-1, and other hormones, contributes to increased obesity and to the various complications that are associated with it. Reversing these dysregulated processes in key organs is an important step towards restoring a healthy metabolic homeostasis.
In this short segment, I'm going to discuss how our novel anti-CB1 therapeutic is able to drive meaningful weight loss and other metabolic gains. We're going to talk about 4 mechanistic pillars, if you will, of nimacimab. Now, before I get into these pillars, I think it's worth noting, and we've talked about this before, that nimacimab is a highly restricted, that is, does not meaningfully enter the CNS and penetrate the brain. And this is orders of magnitude better than even the most advanced small molecule. And because of this unique distribution, we're really looking at peripheral mechanisms. And that does not obviate, however, engagement of the central compartment. That is, we absolutely believe that modulating pathways in the brain are critical to manifest not only weight loss, but other metabolic gains. And so we'll get into this more, but just as a backdrop, our peripheral restricted therapeutic certainly does have pathways to engage the central axis. Our first pillar we're going to talk about is regulation of appetite regulating hormones. So when focusing on the 4 pillars, we really think about initially regulation of caloric intake. And so how can something as uniquely peripheral as nimacimab alter the appetite? And what we're seeing evidence for now in our in vivo studies, in our DIO models, is the modulation of leptin, as well as GLP-1 and other hormones. Notably, however, others have demonstrated that anti-CB1 inhibition can, in fact, increase GLP-1. That's been both clinically as well as preclinically demonstrated. And so we're seeing that as well. This is likely through specific engagement in the GI tract. The other key element, again, is the modulation of adipose tissue in terms of its production of leptin. So hyperleptemia, that is excessive amounts of leptin, essentially can break that signaling pathway. So the first step towards restoration of leptin signaling is in fact control of hyperleptemia. So ironically, reduction in leptin levels is required to allow for reestablishment of that important appetite regulating hormone. So we see that happening in our DIO models readily, and we see increase in GLP-1, which of course can then act distally on the central compartment and allow for reduction in caloric intake. And that is in fact what we see in mice. We haven't eliminated the potential for modulating the vagal tone, and that pathway is still something we're exploring, as well as engagement in areas like the hypothalamus or the area postrema. This would allow for nimacimab to engage outside of the blood-brain barrier and still have a potential effect. So those 2 areas are still being studied and may also play a role, but we do feel confident that modulation of key appetite regulating hormones is in fact our first pillar mechanistically. The next pillar I'd like to touch on is improvement and restoration of glycemic control. Even in patients without diabetes or prediabetes, glycemic improvements are critical in terms of metabolic gains, including weight loss. And so we can see in our DIO models reproducibly that nimacimab is able to have significant improvements. And this is evidenced by not only fasting glucose levels, but fasting insulin levels, both of those being significantly reduced and getting closer to the normal weight control mice. This is very different than the obese control mice, which of course have very elevated levels. And the other key element that we see reproducibly improving is when we feed these mice glucose and look at a glucose tolerance test. So these fasting mice that are introduced to bolus glucose see that nimacimab is able to significantly improve the blood glucose levels much lower than those of their control cohorts. And this is seen through improvements over time, as well as if we look at the area under the curve analysis using this glucose tolerance test. We also see improvements in the insulin tolerance test as well, similarly. So by and large, these improvements we feel are not only beneficial clinically for those that may be pre-diabetic or even diabetic, but importantly, just any patient that is looking to maintain and control their weight via nimacimab. The third pillar I'd like to touch on is productive changes in lipid metabolism. Since we're able to understand body composition in our DIO models, we can dig in deeper and look at the relative weight loss that occurs through fat mass versus lean mass. And nimacimab is able to predominantly drive that weight loss via fat mass. One of the key drivers behind this fat mass specific loss would be related to lipid metabolism, and can in fact nimacimab promote enhanced lipid metabolism. We've looked at this in a few different ways. Importantly, in the liver, we see that steatosis, that is liver fat, is incredibly reduced. We look at this in a couple different ways. When looking in the liver at blinded IHC sections, pathologists were able to score the severity of steatosis. And what was evident is that the liver fat in these mice that were treated with nimacimab was significantly reduced. This was resembling closely the normal weight mice and very distinct from, of course, the vehicle control and even semaglutide, which had some improvement, but not nearly to the extent that nimacimab was able to demonstrate. We also use computer-aided scoring of regions of steatosis, and we could see the same pattern there with that analysis. The other endpoint that we looked at is in the serum itself, and here we can see a significant reduction, particularly at the higher doses of nimacimab, and this again is striking when compared to the vehicle. Collectively, we think that changes in lipid metabolism are one of the key pillars that allow for a meaningful change in not only broader metabolic patterns, but frankly, the body composition that's so critical to meaningful and stable weight loss. The last pillar that I would like to touch on is reduction of obesity-induced inflammation. While potentially not intuitive as to how the inflammatory response may support direct weight loss, there's increasing evidence that suggests, in fact, inappropriate inflammation supports metabolic dysfunction. So conversely, as we see both in the liver and in the inguinal white adipose tissue, we see that a key inflammatory mediator, that is the macrophage subpopulation of white blood cells, being significantly reduced, really resembling, again, those of the control normal weight mice. We see that this population is associated with reduction in fibrotic area in the liver and adipocyte area in the white adipose tissue. And this, again, is indicative of not only reshaping of these compartments, but we know that there is potent inflammatory mediators that, again, can support immune dysfunction, or conversely, when reduced, allows for more productive metabolic changes to happen. And to that point, as we look into the serum, we have cytokine array data while exploratory, yet it suggests that the effects that nimacimab treatment can have are fairly striking and cut across multiple immune pathways. Notably, we see reduction in potent Th1-like cytokines noted by reduction of IL-12 as well as TNF alpha, even Th2, classic Th2 cytokines like IL-4, and even Th17 in complement-based immune mediators are reduced with the nimacimab. So this again speaks to a really profound shift in the obesity-related inflammation, which we think ultimately supports a global, more holistic type of immune or metabolic, rather, rewiring. Overall, these four pillars, while each being distinct, can work in concert to again evoke not only meaningful weight loss, but other supportive metabolic changes, which will lead to a more robust, more tolerated, and ultimately a more effective weight loss regimen.